I will start with what Dr. Shanmugam said, which is very important. While he said that it is very important to remember that the prognosis in type 2 diabetes, in type 2 diabetes and COVID-19 is directly proportional to the amount of hyperglycemia they have. And he also beautifully discussed that the percentage of admission to the ward, 30 to 40% of COVID-19 in the hospitals who get into severe, am I correct, Shanmugam? Who get into severe morbidity, and 25% death, it was because of diabetes mellitus. So if you align the NCD with the COVID-19, the number one is probably hypertension. Shanmugam, am I correct? And the number two, close to it, is the diabetes mellitus, and Abhijit, the third one, very close contender, is the chronic renal disease. So these are the three NCDs which make a great impact, and diabetes is our important thing to today. And you beautifully said the take-home message that that out of the diabetic patients with COVID-19 admitted, about 25% need intensive care. One has to be aligned to that particular message. And your message on the type 1 diabetes was loud and clear. That type 1 diabetes mellitus, one has to be awake to the idea of diabetic ketoacidosis, also the psychosocial aspect of the COVID-19 in the children, type 1 diabetes children, and and of course the vaccination, as Sujoy said, cannot be overemphasized. You also said that COVID-19 in adults has disease-associated risk, as in other cases, and type 1 diabetes increases the risk of COVID-19, and therefore the mortality is high, the morbidity is high. Type 1 diabetics in children or adults are not spared. Now, I just wanted to ask you one question. Can blood glucose control be linked to the immunological aspects that it makes it more prone into COVID-19, Dr. Shanmugam?
Immune response will be altered if there is hyperglycemia. So we very well know from the pathology days itself that chemotaxis and the humoral response and oxidative response mechanism all will be altered due to the hyperglycemia. And the common interlink between the diabetes and COVID-19 is the inflammation. So obesity, diabetes, and COVID-19 is inflammation. That's why steroid is also showing some very good response if you are using steroid at the correct time. And insulin is a very good anti-inflammatory, this one modulator. But what the data says that in the context of infection, most of the people are concentrating on infection and they are forgetting about the glucose level. They are not managing their diabetes very well. So that itself can lead to the immune alteration. That may be the important factor for the increase in the severity. So definitely we need to concentrate on glycemic control.
COVID-19 can give rise to NOD, new onset diabetes. Can COVID-19 give rise to a type 1 diabetes like situation? The new onset diabetes can be insulin deficient diabetes.
Yeah, we do see some cases. Some cases which presents like a new onset diabetes, like presenting with DKA. But we are seeing in our clinical practice on follow-up, we are able to stop the insulin. They are recovering from the illness also. So again, we need to have more time to say whether, because it's an anecdotal cases, case reports, because as I discussed, population-based studies are not showing there is an increase in the incidence of type 1 diabetes per se. But occasionally we do see patients presenting like type 1 diabetes. But on follow-up, most of the patients are recovering. Dr. Sujoy, your comment, your experience on this?
I think so. There's actually a clinical study going on to try and figure out whether actually type 1 diabetes risk is increased. There are several postulated mechanisms, direct beta cell effect, and even for type 2 diabetes, there is effects on increasing insulin resistance at the level of the liver and the skeletal muscle, and of course, the role of steroids. Couple of one or two comments that I would like from you is, see, I work in a government hospital as well as in a corporate hospital, and particularly if I look at the corporate hospital data, I'm not talking about COVID, I'm talking about pre-COVID. At least 1 in 3 individual admitted to the hospital has diabetes. That's our data for the last maybe 10 years. So when we say that maybe 40% of the people admitted in the hospital with COVID has diabetes, does it not indirectly, intuitively tell you that this is essentially a reflection of what the population is like in any case, rather than making people panic about that, the mere fact that you've got diabetes, you've got COVID. The bigger challenge is if you've got COVID, if you not control your diabetes better, you're more likely to land up in the hospital rather than just having diabetes per se. And it's more important to actually manage diabetes both before getting the COVID, during COVID, and after COVID. And like any other hyperglycemia, we've got a lot of studies in the past as well to say that if you have newly diagnosed hyperglycemia on admission to a hospital, you're likely to do badly. Your comments?
Yeah, I think Sujoy will hasten to add, the newly diagnosed hyperglycemia mortality is 16%. Who are already, so Shanmuga, you only give the statistics, and if it is already known hyperglycemia, it is only 3%. So new onset hyperglycemia, as Professor Sujoy said, is more harmful than even known hyperglycemia, because they have been undergoing some treatment which may be beneficial. The last question to you that I like to ask, beyond hyperglycemia, what are the other poor markers of poor prognosis in COVID-19 and type 1 diabetes? I know Shanmuga Sundar, as Sujoy said, the study is going on, but what is your impression? Other poor markers.
Overall, if you combine type 1, type 2 diabetes, it's mainly the associated obesity and the concurrent comorbid condition like CKD, heart failure, etc. plays a major role. And type 1 diabetes, mainly it's age plays a major role, because data says the older adult type 1 diabetes are at risk for mortality, and the associated vascular complication, again, it's an important risk factor. Answering to Dr. Sujoy's question, again, there is one data from the UK. The case fatality rate, where they compare the diabetic population with the general population due to the COVID-19, it's almost 10 times more. The case fatality rate due to COVID infection in diabetes population, 10 times more compared to this one. So again, as you rightly said, the hospital admission, the data are almost similar, 30 to 40%, but the case fatality rate is huge. Probably it may be due to the late presentation or improper use of steroid or poor control of glycemia, which is contributing the case fatality rate more in type 2 diabetics population compared to the general population. So all this factor has to be considered.
One last question, sir, if I can ask. Day 19, your take on your clinical practice with SGLT2 inhibitors in COVID.
You're asking
mild to
me?
moderate, yes.
Yeah, please start. Mild, moderate diabetes. Yes, Sundar, please.
Yes. I will continue the SGLT2 inhibitor, but proper education should be given to the patient. They should know the dangerous sign. Definitely, if the patient requires admission, or we are going to start steroid, or if signs of dehydration, stop SGLT2 inhibitor and start once the patient is stable. Education is more important.
Sujoy, thank you, Sujoy. I will pass on to your professor now, our professor, Professor Abhijit Taraphdar. Sir, I must admit your presentation was fabulous. Fabulous presentation. Take-home message was great. I want to ask you one question. Sir, don't you think the KDIGO 2021 guideline and the ADA the diabetic kidney guideline are almost aligned together, sir? They're almost similar?
So far as diabetic management is concerned, they are alike. But blood pressure, because some of the studies that came, like this MRA studies, those are not there when the KDIGO guideline was presented. So they are not there. So they have been incorporated in the ADA, which was not there in the previous one.
Sir, if you refer to the new KDIGO 2021 guideline, we had only one of our colleague, Sujoy's colleague, Nikhil, who was there from India, sir, from diabetes side. Now, what are the main changes apart from the MRA and other thing? What are the other important changes that you would like to give to our audience who have joined in thousands today, sir? In the KDIGO guideline, what are the new things beyond the MRA which you pointed out? Anything else, sir?
The problem that I've already said, that we actually have accepted with a pinch of salt. Because Nikhil Kannan, he's not a nephrologist, he's a diabetologist.
Yeah, he's a nephrologist.
From All India Institute, he was incorporated in framing the guideline. But what we find, as I have already said, that we hardly see diabetic kids. So the patients that we encounter, they have already GFR less than 30. They already have a progressive loss of GFR. they have hyperkalemia, and they have all comorbidities. So the recommendations, the guidelines that have been recommended in the newer guidelines, those hold good for a diabetologist, because a diabetologist manages a patient of diabetic kidney disease in the early stage, not in the advanced stage. So that is a big drawback, big deficiency in the guideline. What we encounter, there is no recommendation whatsoever what should be the management in terms of blood pressure control or blood glucose control when the GFR is less than 30.
And more people from your field, I don't know what exactly happened. Sir, I'd like to ask one question, sir. Diet, exercise, ACE inhibitors, ARBs, treatment of albuminuria, I mean, they're still the foundational treatment for the decade, sir.
Yes, I mean,
diet, ACIs and
yes. About 40 years ago, when we were undergraduate students, our teachers used to say that the three fulcrums are diet control, pressure control, and sugar control. And after 40 years or so, diabetic kidney disease management remains the same. Only thing is that diet has gone, because if diet results in control of diabetic kidney disease, what the pharma industry will do? There's a reason that there's very little highlight on diet restriction, salt restriction, and the other aspects like dietary phosphate restriction. So nowadays the emphasis.
I'll ask you one question for interest of time, sir. Your professorial comment on the protein restriction. Now, India, we are protein restricted in our diet. So we say 0.3 to 0.8 gram. You know, as Prabha highlighted, 3 to 8, 0.3 to 0.8 HB1 reduction. Now here also we say the protein restricted to 0.8, 0.3 to 0.8. Sir, I have a very focused question. I want your simple guidance, one sentence guidance. Is there a difference between the animal protein vis-a-vis the vegetable protein for the animal protein and other vis-a-vis other protein in diabetic kidney disease, taking into Dr. Mani's contribution?
Thank you for raising this issue. Firstly, Indian diet is uremic diet. Yes. Indian diet is essentially uremic diet, so there is no more stringent dietary protein restriction. Rather, we should restrict on those protein supplements which are rich in phosphate. So our emphasis is phosphate restriction rather than protein restriction. So those protein supplements which are restricted, instead of restricting, there is nothing different between animal or vegetable protein. Go by the phosphate. Yes. If phosphate is there, restrict it. If phosphate is not there, you can take liver supplement.
Yeah, sir, I just want very focused and single sentence answers, sir. Sir, do you think that the SGLT2I can be used? So Credence said, I mean, it was exploratory finding, not the primary endpoint, that up to even 20 or 15 eGFR. Now, others have said it can be used up to 20, and for the UCAR between 200 to 2000. Sir, a single sentence guidance for the country for the SGLT2I, the cutoff at the eGFR, sir. Just a number. It's easy for people like tougher to remember.
So, if you go by the Credence, it's 30. If you go by DAPA, it is 25. If you go by the coming so question is not 20, 25, 30. Question is A, the comorbidities, B, how the patient is tolerating SGLT2 inhibitor, and C, how long you can continue. If you find that this patient is not inhibitor, you have to withdraw. And secondly, most importantly for Indian perspective, the price. If they continue to take SGLT2 inhibitor and they stop antihypertensives, ACIs, ARBs, in the other agents, I think that's a criminal offense. So you should select individualized SGLT2 inhibitor, and that is absolutely.
I think you're absolutely correct, sir. Some of the pro drugs like enalapril are not cheaper. I cannot agree more with you, sir. But the only silver lining that whatever it may be, the dapagliflozin has become very much affordable. GLP-1 are still beyond many of our persons' reach. I never have used it in a diabetic kidney patient. Or my colleagues in JIPMA, you know them, they have used it, but it has become affordable. But I do agree that not at the cost of other essential drugs. Absolutely correct. Sir, I have 1 minute left, and I'll ask you one question before I go to Prabha for the last question. Sir, can I ask you that now I just want to ask you that what are the biomarkers for the diabetic kidney disease, and what is the role in elucidating the patients who are more prone for this, and how to use them very judiciously, sir? Very brief answer. We have only half a minute time, sir. And you tell me, beyond urea, creatinine, EGFR, what are the other markers, sir?
There are a lot of biomarkers.
No, important ones for our country.
No, that's what I'm saying. The biomarkers, whichever have been proposed, have not stood the test of time. So I will not comment on the biomarkers as of now, because this is not the time that we can say, well, this is the final biomarker. There are some individual biomarkers, the tubular injury markers, and there are other biomarkers also. But still, they did not stand the test of time.
Yeah, I think you're absolutely correct, sir. Thank you very much. Prabha, I have the last comment. You have answered beautifully the questions which Dr. Sujoy Ghosh asked you. I want to ask you, Prabha, very important thing is that how do you view the March 29? You also alluded to it, the FDA raising the bar or lowering the bar, whatever you said. And I will say what Deepak Bhatt, whom you quoted, he said about 3-4 days back. He said that if there is no dehydration, no infection, type 1 diabetes ruled out, you use SGLT2. But I want to comment on that. Is it time to let go the CVOT trial? Title of your talk. And what's your comment on that lady who did that, Lisha Yunuf? He gave that talk on the March 29, 2020 of lowering the bar. What's your exact comment? I think it's a welcome move. I think, as Sujoy said, the cost was being billed to the patient, the cost of the big trials. But what you said was prophetic, Prabha. You said about the pre-monitoring, you said about the post-monitoring, you told about 360-degree monitoring. Not only Taraphdar sir, what Prabhakar said, that you don't only consider CVOT, non-inferiority, but go for everything, pre and post, and not only for the CAD, enter atherosclerotic game in the stroke, in the abdomen. I think you mentioned that about other visceral things. Will you dilate upon that point a little bit?
Sir, what she wanted to say was that this lowering the bar is actually going to make it cheaper, because obviously the cost is coming, which is what Dr. Sujoy was also telling me, that the cost is going to be borne by the patient. But at what cost? Ultimately, if you look at the SGLT2 inhibitors and the SAXA, I think we have had a much better price in terms of treatment effect. Now today, what we are looking at is treatment of diabetes with drugs that are going to reduce cardiovascular mortality, which is not there. So I think there is somewhere somebody has to pay the price. But the post-marketing surveillance is never going to be equivalent to a randomized control trial. That is something that we must understand, because ultimately an RCT is an RCT.
Yeah, and also Sujoy will agree with me that without these trials, we would not have got the benefits of the SGLT2, not only anti-diabetic, the drug working for Abhijit Taraphdar filter, your professor Abhijit Taraphdar filter. It is working for the arteries of Prabha, and also of the pump of Prabhakar, the pump, the filter, and the pipes. Without this study, sir, we would not have known this myriad benefits. Am I correct? Sujoy, I will ask your professor. If you would not have done those CVOT trials, sir, do you think you would have brought on those benefits that this drug is for the pump, filter, and the pipe? I mean, there is some good thing, as you rightly said, Prabha, which is built in the trials. It's costly, but I think we have to strike a balance between the two. I'm not very happy that everything went off. Now, the final question, Prabha, to you is that how do you see? You said that what type of bar, from the point of view of cardiovascular benefit, you will put for the anti-diabetic drugs?
So the cardiovascular safety, I don't think is much of a question, because even the rosiglitazone fiasco that was there has been subsequently more or less cleared. So I think the data, the way it is interpreted is very different. Safety of these diabetic drugs, there have been some questionable issues with several drugs. We don't want to go into specifics. But I think you need what the FDA got spot on, I think is correct. I think they wanted about 4,000 patient years with 1,500 patients with 1 year and 500 patients with 2 years. They also went ahead and gave specifics of about 500 patients who should be having CKD stage 3 or 4, 600 patients with cardiovascular disease, and 600 patients with age more than 65. Okay, they've got everything, but they left out the large chunk of patients. I think there should have been something on that, and some kind of follow-up. Probably they have to add it to say that it has to be more followed up.
I think you rightly. Let us conclude. Sujoy, I'll ask Sujoy to conclude the session. Before that, one sentence that we had to take care of the safety data, take care of the elderly people safety data. Younger people were not included. Sujoy, am I correct? In those CBOT trials, younger people were never included. So the guideline in the ADA said clearly that we have to take care of the diabetes in the young, which have to also look to the cardiac safety data and a lot of the things. I think, Sujoy, one sentence wrapping up.
It's always a pleasure to share this screen with you. In terms of the CV outcome, I think 10 years down the line, we will be criticizing the new guidelines because we would be wiser then. But it's much easier to criticize, retrospectively. But I think we are trying to improve on what was currently available. In terms of the kidney outcomes, I think I'm excited because ever since I was an MBBS student, we were taught about the IDNT and the renal study. Thereafter, we did not have anything in our armamentarium. Though we should not go gaga over it yet. Still look at other aspects of the renal protection with the newer drugs as well, because some of the drugs have failed. And as an endocrinologist, as a diabetologist, we have to watch out more and be more careful about our patients, particularly during these COVID times, and help them achieve better glycemic control and better outcomes.
Session. My regards to, both Prabha and Shanmugam are my very close colleagues. My regards to Professor Abhijit Taraphdar, sir. Wonderful presentation. As you said, the triangular approach of diet, blood glucose control, blood pressure control. Now we have got in both the arms, blood pressure control, blood glucose control, newer drugs. Maybe that's the message that the ADA gave, that you can good SGLT2 inhibitor you can use. Of course, the bars you have pointed out, you have quoted Mariama's talk, but the majority of the evidences probably today, excuse me for saying this, are that one can possibly use drugs which are new in the anvil, like SGLT2, GLP-1 array, and also new blood pressure controlling drugs. Thank you very much. Wonderful session. My regards and thanks to Abhijit, and my love and my greetings to Shanmugam and Prabha. Thank you very much. And Sujoy, as usual, you are fabulous.